All right, so someone asked about decompensated childhood strabismus and phorias. And as you know, a phoria is a tendency for your eye to drift, but you're able to keep it in check with fusion. And the way we record these phorias is with just a single letter, so esophoria or exophoria that's what that means when we have it like that. And it can become tropic, esotropia or exotropia. And so when someone has a manifest deviation and is symptomatic, that we call tropia. And that's because their fusion is broken down. But there's this intermediate step that it might go through, which is an intermittent esotropia or an intermittent exotropia. And we record that by using these parentheses. So we have the phoria, the intermittent tropia, and the tropia. And so patients who have childhood strabismus might present in adulthood from decompensation of their fusional mechanisms, leading to breakdown of their phoria and manifesting either intermittently symptomatic as an intermittent tropia or constant deviation, a manifest tropia. And so the key and differentiating features for this decompensated phoria are, number one, the patient tells you, I already had a tendency for my eye to drift, or they had childhood strabismus surgery or patching in childhood. So you have to get this history out of them. And you can look for an anomalous head tilt or a face turn to suggest that it's long-standing. And so we call that FAT scan before the CAT scan, which is family album tomography or Facebook album tomography before they have the imaging study, FAT scan before the CAT scan, to look for this anomalous head position. And for vertical deviations, where we're worried about a long-standing fourth, we can measure their fusional amplitudes and see if the patient has large fusional amplitudes, which would suggest that it's a congenital or long-standing old fourth nerve palsy that's decompensated. And for the horizontal deviations, if it's childhood strabismus, there's not going to be any ductional deficit and they're going to be comitant. So those are the two pieces of information that we'd like to know. What are the ductions? So if we have a ductional deficit, that is actually suggestive that it could be neurogenic or myasthenia or the muscle, versus if their ductions are full, it's much more suggestive that it's a fusion problem. And we'd like to know if it's incomitant or comitant. And comitant means that it's the same in all directions, and incomitant means it's different in different directions. So when you have a sixth nerve palsy or lateral rectus palsy, it's going to be worse in the direction of that muscle, but it'll be less when you look away from the action of that muscle. And so that'll make it an incomitant deviation. In breakdown of phorias, the deviation is the same pretty much in all directions of gaze, because it's not really a problem with the eye muscle or the eye junction or the nerve. It's a problem with fusion. And so that fusional problem is kind of the same in all directions of gaze. So you really have to do a good exam to try and identify that there's no ductional deficit and the deviation is comitant. Now, before you blame it on just decompensated phoria, you do have to work it up. Of course, myasthenia gravis and the most common muscle disease, thyroid eye disease, can manifest as a decompensated phoria. So the usual suspects, nerve, muscle, and connection. Our most common decompensated phoria in neuro-op is actually this one right here, which is an exotropia. And usually that exotropia is more set near, and that's because of convergence insufficiency. And we record the near with this little apostrophe looking thing here, a prime sign. So exotropia greater at near because they cannot converge, and full ductions inversions, distance is better, and a comitant deviation in primary position from the right and left gaze. That's a incomitant versus comitant deviation. Comitant, near only, XT, we're going to be picking convergence insufficiency. That's our most common decompensated phoria in adult neuro-ophthalmology. So you need to take a good history. You got to do a FAT scan before the CAT scan. You got to do a good exam to make sure there's no ductional deficit, that the deficit is comitant. And then you got to think about the usual suspects, nerve, muscle, or connection, before you make the diagnosis of decompensated phoria.